Good afternoon, everybody. Neuropathy is a multifactorial complex process in which peripheral and cranial nerves they are pathologically affected with partial to complete damage, which may be reversible or irreversible, and the axons, myelins, or both might be affected. As peripheral nerves are mixed, they are having the motor, sensory, and autonomic component. Any of these components might be affected in isolation or in combination, giving the different clinical situations. Just to know the basic physiology, the motor nerves are large myelinated fibers. Proprioception and vibration, which we routinely test, is also by the large myelinated fibers. And pain, temperature, and autonomic functions, they are by the small myelinated as well as the unmyelinated fibers. So common causes to enumerate for the neuropathy: the hereditary, compressive, metabolic and hormonal, which we will be discussing, infective, autoimmune, nutritional deficiency, which usually are treated at the general practitioner level only, the drug-induced, and the cryptogenic or idiopathic neuropathies. The neuropathies may present as a mononeuritis. They are usually common in the compressive neuropathies, mononeuritis multiplex in connective tissue disorders, and the polyneuropathies in metabolic as well as the drug-induced neuropathies. So these also may present as an isolated motor, isolated sensory, mixed, or the autonomic presentations. Today, we are going to discuss the neuropathy, which is commonest on day-to-day practice, and that presents as the surgical case in our OPDs. It's a conference of orthopedic surgeons, so we are focusing on the neuropathies which are going to cause the surgical issues. So the diabetes neuropathy and its mimics we are going to see today. It may present as simply a callus at the one spectrum, and the most dreadful disease, that is the Charcot, at the other end of the spectrum. As diabetic neuropathies involve foot predominantly, our today's topic is neuropathic foot from basic to Charcot. Is this topic relevant to our theme, the newer implants and newer techniques? Yes, but there is no implants, but the new techniques and something totally new for our orthopedic fraternity. Recently, orthopedic foot has involved in the FRCS ortho exams also. So diabetic neuropathy, what causes the neuropathy in diabetes? The glycosylation products which lead to the microangiopathies and the microischemias of the nerves. That is the common cause which we know. But additionally, there are nutritional deficiencies, the chronic uremic status causing its own toxicity on the nerves, the retinopathy which reduces the vision and causes trivial traumas to the old age patients, associated thyroid imbalance, and the glycosylation proteins which accumulate in the interstitial spaces and cause the compressive elements, and loss of arch of the foot eventually, which causes mechanical trauma to the nerves. So we should know what is the spectrum of presentation of in these neuropathies. The most common is the DSPN, that is the diabetic distal symmetric sensory and sensory motor neuropathy, what we classically call as the glow and stopping anesthesia and the paresthesias. And the other components, as I already told, that can be autonomic. The radiculoplexus is one type in which you get the presentation of claudication right from the lumbar region up to the lower limb. Sensory neuropathy may present with the positive and the negative symptoms. The positive symptoms are pain, paresthesias, burning. They are usually in the early course of the diabetes, while the negative symptoms of anesthesia, loss of proprioception, loss of balance, and the loss of pain sensation, that happens as the disease advances. Negative symptoms are more dangerous because no symptom, no treatment, and complications. That is the dictum. So motor neuropathy may present as a weakness of intrinsic muscles, the decreased range of movement, abnormal gaits, and the proximal myopathies. I have purposefully extended introduction of the neuropathy here because it's all new to us. So how to evaluate neuropathy? The neuropathy evaluation is basically done by a physician who is treating diabetes, and a sensory component is tested with certain instrument that I will show in the subsequent slide. In the motor assessment, power of the muscle, range of the movement of the joints, especially the first metatarsophalangeal joint and the tendo-Achilles, and autonomic neuropathy as the testing of BP and pulse in the different positions. Vascular evaluation is equally important at this stage, and Dr. Kamerkar and Dr. Zadav will cover on the vascular issues. So how to assess the neuropathy? Monofilament, 10 gram, it touches the mechanical pressure. 128 volts tuning fork, it senses the vibration but it is little non-objective. And biotheziometer, it will give a more objective values for the study and the research. So this is how the biotheziometric values come. On the right side, I have put a more or less normal foot. Less than 15 is normal. 15 to 25 is early neuropathy. 25 to 40 is moderate neuropathy, and 40 above is the significant or the end-stage neuropathy. So on the right side, you can see everywhere OR. There are the no responses felt, and the left foot I have presented. These are the actually lab studies done in my lab. But these two tests, they don't predict the possibility of ulcer development in a patient. So dynamic studies where what we call as the pedobarogram, or the walking studies, or the studying the plantar pressure while the patient is walking, are important, in which patient walks on a heated pad on a specialized paper which is analyzed with the computer and its software, and we get these kind of images. So now here you can appreciate there is a callus. We will see what is a callus in subsequent slides. And you can see this is all green and blue. If it is green and blue, we are in a safe zone, and you get a red, that is indicative of in this patient there are the high plantar pressure. This patient has high propensity to develop the ulcers. At the same time, I will show you an opposite scenario. Patient has got ulcer on the medial side, but he is having a compensatory walk, so the high pressure points are on the lateral side. So this patient is little safe. He is offloading himself, and the wound should heal just with the lutein dressings. With this introduction, so how the callus and the things are going to form. So callus is the thickening of the skin because of the abnormal pressures. Below the callus, there will be the formation of the hemorrhage. This will breach, this will break, and it will form an ulcer, and ulcer will lead to the bone, and it will cause the osteomyelitis. So this is how a simple looking callus will ultimately lead to a deep tissue infections. So now the question is how to treat the neuropathies, and the answer is being humble and taking the example of the God. So this is Urvamulam Adashakham Ashwatham Prahuravyam Chandasi Yasya Parnani Yasta Vedasa Vedavit. याचा जर अर्थ डिस्कस करायचा लागेल तर खूप दिवस लागतील, पण एका वाक्यात सांगायचं झालं तर आपला सामान्य लोकांचा आयुष्याकडे बघण्याचा दृष्टिकोन आणि भक्ती मार्ग आणि ज्ञानमार्गाच्या लोकांचा आयुष्य हा पूर्णपणे उलट असतो. रुटीनली झाडाची मुळं ही जमिनीमध्ये आणि शाखा वरती असतात, पण भक्ती मार्गामध्ये ह्याला एक्झॅक्टली अपोजिट वेनं बघितलं जातं. तर वी हॅव टू थिंक आउट ऑफ अ बॉक्स, वी हॅव टू थिंक इन अ रिव्हर्स वे. देर इज समथिंग कमिंग फ्रॉम अबव विच इज कॉजिंग द प्रॉब्लेम. यू कॅनॉट ट्रीट इट बाय गोईंग फ्रॉम द बिलो. सो it is not a triumph of just a debridement, dressings with fancy lotions, solutions and the creams, and at the end of the day you lead to the amputation. Principle of management of neuropathic plantar ulcers is offloading. Offloading is taking the pressure out of the foot. What matters is what we can take away from the ulcer, and that is the answer is the pressure. So there are different modalities. We can do a temporary offloading with different kind of shoes. This is the heel offloading, this is the forefoot offloading, these are the peg offloading, this is the airwalker cast. These are ready-made devices, and these all in the last row, they are customized devices made in the OPD. A cobbler sits in my OPD twice in a week to give specific offloadings for these patients. Surgical offloading, whether it would be a permanent solution, nothing is permanent solution in diabetic foot because doctor's role is minimum and patient's role is very high, and that there is possibility of repeated infections. But we can see certain tendon procedures like tendo-Achilles lengthening. You can see here the tendo-Achilles is usually shortened, it causes the forefoot pressures. Then peroneus longus to brevis transfer for the patients who are having the ulcers under the hallux, and EHL proximal shift towards the first metatarsal and causing the tenosuspension. So these some mechanisms might be helpful on the tendon procedures. While excision of the metatarsal heads, the modified or the wheels osteotomies where the metatarsal head is rotated in opposite direction, Keller arthroplasty for the first ray, bumpectomies and the fusions for the Charcot and complicated foot. So now we will go case by case. The first case is a callus, simple. See, in this toe, the thickening is on the plantar side and you just remove this callus. Fortunately, we have arrested at the hemorrhage site. On the contrary, if this would have been presented as a wound at the tip of the toe, we would have more called it as the neuroischemic ulcer rather than the pure neuropathic ulcer. Case 2, again the callus, but approach is different. Patient has presented with a callus on the third metatarsal head. X-ray is not significant. Always go for the standing X-rays in the diabetic foot. So ulcer, the callus is elevated. Below that hemorrhage, below the hemorrhage there is an ulcer. Ulcer is going deep up to the bone. So excision of the third metatarsal head is the treatment in this patient, and the wound has started healing signs. Next is of the callus, which we have already seen in the plantar pressure studies. Here callus is at the IP joint, and in this type of IP joint calluses, it is usually the metatarsophalangeal joint which is either rigid, that called as the hallux rigidus or hallux limitus, and here we have to do tendo-Achilles lengthen. It is percutaneous, followed by modified Keller, that I did the capsulotomies and afterwards give the offloading and the callus has been managed. Why I am so much focusing on the callus? Because it is like you should do an angioplasty of a cardiac patient before he gets MI. After the heart is damaged, there is no point in doing. So callus is the stage where we can arrest the disease and we can arrest the major complications and amputations. So now a clotto. History is very important. Patient presented to me with amputation of the first toe already happened outside, non-healing wound on the second toe and 3 clottos. I digged out the history. History of diabetes was only for 1.5 years. Not explained. More detailed history explained. Patient has a severe alcoholism. So it is essentially an alcoholic neuropathy. Diabetes is adding just a salt in that. So after doing the clotto release and prevention of alcohol, patient is stabilized at this stage. Patient presented with a non-healing wound on the medial side, debrided 4 to 5 times at different centers, came to me. So X-ray, nothing difficult to diagnose. Classical osteomyelitis, this is the most common area of the osteomyelitis in case of the diabetic foots. So first metatarsophalangeal joint osteomyelitis. The infected area was removed, including the sesamoid bones. The flexor hallucis longus is the key player in this kind of injuries. So it is excised from behind the ankle and the fixator is applied. And you can see the wound is healed within 2 months' time. Usually Diabetic Society considers 100 days is a reasonable good outcome time. Anything less than 100, we should take it as a good surgical procedure done. One more patient having the neuropathic 2 years on and off ulcer. On detailed inquiry, not diabetic, but he was the Hansen's disease. We can see the osteomyelitis of the distal end of the proximal phalanx. But see, clinically now you will see what is the difference. So the affected foot is more cavous and the opposite side was the foot was the flat. So in addition to a routine orthopedic principle, that is removal of the osteomyelitic segment, application of the fixator, FHL was also excised and peroneus longus to brevis transverse was done to offload the first ray, and the wound is healed at the end of the 2 months. And still, as on today, it's one more thing, as in cancers we say the disease-free status, in diabetic foot we say it's the ulcer-free status. So is the playing with the tendons you feel amazing? So let's see what can go wrong if we play with the tendons. You can appreciate that one toe is already lost, which I only had removed, and at that time I had done the percutaneous TA lengthening. Again presenting with the forefoot ulcer. So second and first metatarsal heads, and there was an abscess. So I thought that my TA lengthening was not sufficient. Did open TA lengthening, debridement, excision of metatarsals, fixator, all principles were followed. Result, wound has healed, but within 3 months patient came with the calcaneal ulcer and the calcaneal wound, because lengthening of TA is going to cause the calcaneal gate, and a patient whose sugars are not in good control and who is not obeying patient, they will come this with along with came the sepsis. This was the time where I asked whether we should go for the amputation, but still not willing. So debrided, VAC, skin grafting. Again break, he is working on that, not ready to offload in any kind. Again one more debridement, this is today's status. So one more question raises here, whether we just have to want a limb or we need a functional limb. So sometimes amputation with good prosthesis may be an answer, or maybe we will be thinking about the reverse coronary artery flap in this patient. So we'll come to the next most dreadful issue of the neuropathic foot, the Charcot, which is most ununderstood enemy of the foot. The different pathophysiologies have been, or the sequences have been suggested. Autonomic neuropathy causing the vasodilatation, which flushes the bones. Some trivial trauma that causes the uncontrolled inflammation in the area, ultimately causing the swelling and fragmentation of the bones, which eventually goes to the coalescence of the fragments, and malunions, non-unions, collapse of the foot, loss of arch, abnormal plantar pressures, and ultimately pressure leading to the wound, and the wound causing the infections. The same sequence which we had seen in the first slide, that is the basic slide. How there it started from the callus, here it is going to start from the edema. So acute Charcot and chronic Charcot. In acute Charcot, patient will have overnight sleep and morning he will come with painless red swelling of the foot and ankle or maybe a leg, increased local temperature. How to differentiate from the cellulitis? A swollen foot in diabetic is altogether a different topic, but our routine concern whether it is a cellulitis or infection or it is a Charcot. So normal total counts, procal is normal, and most important, temperature reduces with elevation. You put the patient on elevation for 12 hours, the temperature will reduce in a Charcot and temperature will not reduce in the case of an infection or cellulitis. So this is how a typical presentation, one-sided edema, and focus here. So these two skins rise is more or less pathognomonic of a Charcot process. Treatment, total contact cast, because the total contact cast works by the two principles. It reduces the edema, it grades the offloading, it distributes the pressure and immobilizes the bone. Minimum 3 months followed by next 3 months is the period. In first 3 months in Charcot foot, it is not recommended to go by the surgical fixations. Literature was confusing when I started treating Charcots 15 years back, and still it is confusing. So one has to take a call depending on the clinical situation. Standing X-rays, fragmentation of the bone, earliest sign, and the thickening of the skin. These two signs at very low cost device to diagnose the Charcot. MRI is definitely the gold standard. The TCC started for this patient, and see within 2 months those fragmentations have been lost, patient is still under the treatment, arch is still maintained. But every patient who is untreated or half treated or best treated, he may not have a good outcome, because disease outcome is not in control of the surgeon or also in the patient. So it may lead to a total collapse foot, what we call as the chronic Charcot. Arch is collapsed, talus is coming the ground. Usually the disease process, maximum Charcot we will see in the midfoot, but its consequences are in the hindfoot, and the talus on the ground and the non-healing plantar ulcers will be the scenario. 2 years wound, patient roaming here and there, ulcers on the forefoot, multiple debridements done at multiple centers, but in X-ray you can see the talus is on the ground, just prophylactic offloading is not sufficient, patient is treated with the talectomy, TA lengthening and talocalcaneal fusion with the bone grafts. At the end, 6 months absolutely non-weight bearing, no shortcut in that, and the wound has healed and patient is being treated with the rocker bottom foot for whole of the life to prevent ulcerations at other places. One more case, burnout patient of a Charcot presented to me with both fit cellulitis. It's a time to keep patience, don't hurry for the bony procedures, just a debridement, non-weight bearing absolute bed rest, multiple settings of WAC, and the wound healed at the end of 3 months, and then patient was walked with the air cushion walker. So this chart will give you an idea. Neuropathy, foot deformity, plantar ulcers and PVD, these are the 4 components. And as we go or descend towards this corner, when all things become more and more severe, our treatment strategies has to be changed. So for all this red zone, initially they used to recommend some modified shoes only, but nowadays prophylactic surgeries play a role here to prevent the major amputations. So diabetic foot management is essentially a damage control treatment. There is always a loss in capital which we have to accept. Minimizing the loss is the success. Amputation is never an defeat, but it's a beginning of a new battle. So, let it not be a shokantika which begins with the callous because of the callous attitude of the patients, doctors and society towards the diabetic foot. Let's bring some change in attitude, and that attitude will give a big difference and salvage of the limbs, and we can save more limbs of the diabetic foot. The lecture cannot be complete without paying tributes to this gentleman, Dr. Paul Brand, who's tried to change the treatment options in the leprosy and leprosy neuropathies, and on whose work hold the pillar, or on that pillar hold the building of diabetic foot management is sustained. So this gentleman, Dr. David Armstrong, my teacher, he tried to bring change in me, and I am trying to follow that change, but I am alone not sufficient, because managing diabetic foot is not an individual person's job. A team of surgeon, nephrologist, diabetologist, radiologist and critical care medicine, along with Dr. Prithvi, who is sitting there as my interventional radiologist, that all team is required to give the best possible outcomes in the diabetic foods. The team which is working with me from day one of my practice, and relentlessly they are learning the new things in the field. That is also important, that what to do and what not to do in case of the foods, because I will do a surgery, but they are going to manage the dressings and other post-operative protocols. We all are talking here in the 5-star hotel with the best possible shoes, in the best possible atmosphere. पण ज्यांच्यासाठी आपण हे सगळे करतोय ते ऑलरेडी अनवाणी पायांनी पोचलेले आहेत, कारण त्यांचा आणि आपलाही देव युगानुयुग अनवाणी पायानं प्लांटर प्रेशरची फिकीर न करता विटेवर आपल्या रखुमाई सकट अनवाणी पायानं उभा आहे. सो लेट्स मेक इट अ कमिटमेंट. त्यांच्या पायासाठी लेट्स मेक इट. It's the Surya Super Speciality Diabetic Food Services. I call it the Surya Limb Mission, that is the Ghost Limb. It is dedicated to all the people, all the patients with the Limb Salvage Alliance. Thank you very much.